Thank you for the invitation to the Smile Train organizers, and I will talk with you about our experience in finding predictive factors in craniofacial development. Nothing to declare conflict of interests, and the factors that organize the future of a cleft patient will be the hereditary ones, the teratogenic, and the acquired. Hereditary, it's intrinsic to the surgery, to the pathology, and it means the cleft type and cleft severity. And they are linked with ethnic and syndromic cases. The teratogenic after birth and the muscle action to the facial skeleton can disturb and produce problems in breathing and feeding, and we need to have the adequate instruments to deal with them and also correct the tongue position. And the most important for us, and that one that produces the bad outcomes, are those linked to the surgery to correct the cleft. The surgical repair, not only you have ancillary processes, procedures that can determine surgical techniques. They can be responsible. Surgeon skills, of course, it is. I'm quite sure about that. And the protocol stages. To avoid what? For example, to avoid both denuded areas that a technique must emphasize, tension, avoid tension, and don't touch in some areas that can disturb the growth of the face growth. And the main outcomes that we can judge are, of course, the lip and nose appearance, the velopharyngeal proficiency, and the facial growth. Some general factors as patient age, patient general health conditions can affect that. But the most important are specific, and they include the anatomic and functional features, the treatment protocols, and the cleft severity. We have in the world three main groups of protocols. The early one stage palatoplasty, that it's almost 80% in the United States of surgeries to correct the pathology are done under this protocol. And we have the Summerlad proposal, then 2 stages, early hard palate closure. And beginning in Sweden in the last century, the 2 stages delayed hard palate closure. And we publish a paper relating the research that we have done comparing 2 protocols, the normal one, the most used one, and the protocol of delayed hard palate closure. And it's a randomized clinical trial. The sample was UCL patients, 32 from the intervention group. Those ones were submitted at delayed hard palate closure, and 30 with the normal protocol. And to evaluate the facial growth, you use the 5-year-old index, and posteriorly we use the Gaussian yardstick. This is the new data that we are bringing in this meeting. And Comparing using the 5-year-old index, we find statistically difference between those two groups and better results related to growth with the intervention group or delayed heart palate closure. But we didn't stop, and now we have made a new study with the Gosling yardstick at 8 years of age. And we still have the same findings, better outcomes related to surgical protocols with the intervention group. And a lot of people say, but about speech. We evaluated the speech, and I must tell you that we are very strict with these evaluations. All the panelists, all the raters of these studies are not from our hospital, are from, for example, Bauru and João Pessoa, another center in northeast of Brazil. So, and we found that there's no statistically difference when rated by the 5-year-old index, the attack index, and there's no difference between those patients, those two groups, about speech, about articulation errors and hypernasality. And if you can compare this, in this evolution, maxillomandibular growth, we see clear, better outcomes in those delayed heart palate closure. And we also make a thrill about cleft severity can affect the outcomes. We use the measurements of the palate and also the size or the width of the cleft. And both two groups are included, the patients with, there's a sample homogeneity between these two groups, and using the Spearman correlation test, we didn't find no difference between these two groups. And related also to the outcomes, the best outcomes, of course, 1 and 2, there's no difference between this. So the Spearman test also included this, and we look for, there's a problem with hypernasality in the patients with severest features. No, we didn't find that, not hypernasality, not an articulation errors. And now we must think, and the contribution of Rose Lacerda about what to do in the future. We know that we have some data supporting the idea of one protocol, but I believe, firstly, I believe that we must prepare ourselves to have different individual protocols, not the same surgery for everyone, not the same protocol, because there's different phenotypes, so we must face different techniques and different protocols. Thank you very much, and we finish with this. No correlation was found between cleft dimensions and facial growth outcomes evaluated by 5-year-old index or also evaluated by Gosling yardstick. no correlation was found between cleft dimensions and speech outcomes. Significant correlation was found between maxilla size and facial growth outcomes. And the outcomes related to surgical skills, surgical protocols, and genetic induced morphology. Tailoring individual treatment protocols, it will be, of course, our task, and improve better image methods in order to have data, have helpers to find out what's the best for the patient. Thank you, and I will invite all of you, if you want to share next August 17 to 19, the Brazilian meeting in clefts. Sorry, and thank you.
¿Se quiere sentar acá?